I'm the Chief of Pulmonary and Critical Care Medicine at Albany Medical College, Albany, New York. And I'm going to talk for about 15 minutes about a survey study we did concerning sarcoidosis patients all over the world and the impact of the coronavirus COVID-19 infection in those sarcoidosis patients. So just give me a minute to put up my screen. Okay. So as I'm sure everyone knows, there's a pandemic going on, and it's due to a virus. The official name of the virus is the Severe Acute Respiratory Syndrome Coronavirus 2, or SARS-CoV-2. That's a mouthful to say, so we abbreviate it COVID-19. The 19 stands for the first case identified from this virus in the world, which was in Wuhan, China, in late 2019. As we all know, this has become a pandemic and infected millions of people across the world. I just today looked at the New York Times data, up to date as of 9/11/2020, which is when I'm speaking to you. And in the world, there have been 28,000 cases with over 900,000 deaths, almost 1 million deaths in the world. As of 9/11/2020 in the United States, there have been almost 6.5 million cases and close to 200,000 deaths. Now, what is of interest to you and interest to me is, are sarcoidosis patients at higher risk of being infected with COVID-19? And do they have a worse outcome from COVID-19? The bottom line is that we don't know. And I think in terms of the risk of being infected with COVID-19, I'll show you the data. But right off the bat, I want to make an important point. I don't know if you can see my bubble on the side of the screen, but I think the most important thing about the risk of being infected with COVID-19 has nothing to do with sarcoidosis. It has to do with this. The most important thing to avoid infection is social distancing and wearing a mask. Washing hands, avoiding close contact, and cleaning and disinfecting surfaces frequently probably has a role, but I don't want to belittle that. That should all be done. But this virus is most commonly, we believe, transmitted by aerosol in the air, and social distancing and wearing a mask is paramount to avoiding infection. Now, so I don't think sarcoidosis patients may be at a greater risk of developing infection. And in fact, part of what I'm going to show you is going to look at that question. But if a sarcoidosis patient became infected, would they have a poorer outcome than the general population from a COVID-19 infection? Well, there are some reasons why they might have a worse outcome. One is that the lung is the most common organ involved with sarcoidosis, and we know patients with lung disease, from data that we already accumulated from the general population, patients with lung disease have a worse outcome if they become infected. Patients with sarcoidosis are on immunosuppressive medications, and that can block the immune system, and that might promote a more serious infection from COVID-19. Also, prednisone and other steroids, which are commonly used for sarcoidosis, cause side effects and complications, including diabetes, high blood pressure, and obesity, gaining weight. And we know that those three things, diabetes, high blood pressure, and obesity, are associated with worse outcomes in people who get infected with COVID-19. And since patients with sarcoidosis get prednisone, they may get these complications, which may put them at high risk of a complication. We also realize that some minorities in the United States, including African Americans who have a higher rate of sarcoidosis, seem to have a worse outcome. That may be because minorities have more jobs where they're in contact with the public. They can't work from home as reliably with the jobs that they have. That might be the factor that's involved in that, but for whatever reason, African Americans seem to be at higher risk of a poor outcome. And then we wonder if sarcoidosis itself, the disease, could be associated with a poor outcome. So this is something that you know as a sarcoidosis patient. Sarcoidosis patients are worried about this. They're worried about the fact, or they're worried about whether their sarcoidosis will predispose them to a bad outcome. I know this because I see hundreds of patients with sarcoidosis, and this is a common worry that they have. And not only are the sarcoidosis patients worried about it, but the doctors who are taking care of you are worried about it. I was the member of about a 20 to 25 group of international sarcoid experts who wrote a paper in the journal Chest, a prominent pulmonary lung journal, about recommended modifications of immunosuppressive treatment of sarcoidosis because of the COVID-19 pandemic. So patients are concerned about this and scared. Doctors are concerned about this and scared. But we don't have any real data. We're just guessing about what the risk is in sarcoidosis patients. And that's why we conducted a survey. A survey was conducted by the Foundation for Sarcoidosis Research and other entities of sarcoidosis patients to get some understanding and gain some data from these patients in terms of the risk of infection and outcome from COVID-19 infection. It's a little complicated. There were actually 5 surveys because this was an international effort, and so we needed different surveys for different languages in different countries. And the surveys were also different because certain of these foundations or groups that were putting out their survey had certain restrictions or requirements for them to conduct their survey. So not exactly all the questions were identical in all the 5 surveys, but they were very close. I'm going to show you the questions that were in the Foundation for Sarcoidosis Research survey. And I don't know if you can see this too well, but I'll read it to you. The first question was, do you have sarcoidosis? I didn't put that there. The second question was, have you been infected with COVID-19? Yes or no? And if yes, were you treated at home? Were you treated in the hospital? And if you were in the hospital, at any time, did you have to be treated in the intensive care unit? And at any time, were you on a breathing machine? The next question was, are there any people who live in the same residence as you do who were also infected with COVID-19? Also, are you a healthcare provider? These patients were asked if they had sarcoidosis, and if they did, how many years they had sarcoidosis, and did they have any other health conditions which we know carry a risk of a poor outcome from COVID-19 infection, including COPD, asthma, cancer, diabetes, heart disease, hypertension. We asked them their age. We asked them their race. We asked them their sex. We asked them if they lived in the United States, and if so, which state did they live in, or if they lived in a country outside the United States. We asked them in which parts of the body did they have sarcoidosis? Did they have it in the lungs, heart, brain, or other areas of the body? We asked them what medications they were using for sarcoidosis, if any. Were they on prednisone? Were they on methotrexate, azathioprine, mycophenolate, leflutamide? You may know some of these drugs. Were they on a TNF-alpha antagonist like Humira or Remicade? Were they on hydroxychloroquine or chloroquine, rituximab, or other drugs? And we asked them if in the past they had been treated with those drugs I just mentioned. So that was basically the survey. And we did this for about 2 months. We did it at the University of Cincinnati and Albany Medical Center. That was one of the surveys. The Foundation for Sarcoidosis Research had another national and international survey. And then there were surveys done primarily in the Netherlands, Italy, and Spain. And we actually collected 5,200 sarcoidosis patients over that time. What we found was that 114 of them, or 2.1%, stated that they had been infected with COVID-19. Now, this is very complicated, but that rate appears to be higher in these sarcoidosis patients somewhat than the general population. The reason why this is complicated is shown in the next few slides. This, again, I put in today. This is from the New York Times, the rates of COVID, the numbers of cases of COVID in the United States. This is the number of cases of COVID-19 in the United States per day from March to September. As you can see, we had a kind of a first wave that started in March and peaked in April and May. And then starting in June, we had a second wave that peaked in mid-July in the United States and is still high but coming down. So if we want to compare the rates of sarcoidosis over a certain time period with the rates in the United States, it depends what time period we're looking at. For example, the survey was done kind of between May and July in this area. So we need to look at the rates of COVID-19 in our sarcoid patients in the questionnaire in this period and compare it with the rates in the United States over this period. If we pick another period in the United States to compare our sarcoidosis patients with, we may get a false interpretation of the relative rate of COVID-19 in sarcoid. And then to make it even more complicated, even if we get the timing right, a lot of these surveys, including the FSR survey, were done in multiple countries. And again, I put up data today, September 11th, from 6 countries. You can see the rates at different times were very different in these 6 countries. So we have to not only adjust the rates for the exact time period when we did the survey, but we have to adjust it for the number of patients who fill the survey in each country. So you can see that's a very complicated analysis. And when all is said and done, it looks like there's a slight risk, greater risk in sarcoidosis patients than the general population of contracting COVID infection. But I would just caution people not to make too much out of this because there's so much data manipulation in figuring that out, it's a questionable result. But we could say a lot of definitive things from the survey. One thing we can say is something that we know across the world, which is that if you have a roommate who is infected, your odds of being infected were much higher. HR means hazard ratio, and it's basically how many times greater the risk was. So if a sarcoidosis patient had a roommate, someone who they live with sarcoidosis, the odds for them of getting COVID-19 infection were 28-fold higher. And there was an increased rate of COVID and sarcoidosis patients who were healthcare workers, who had pulmonary sarcoidosis, who had neurosarcoidosis, or were receiving rituximab therapy, not a very common therapy, but a therapy that is given to some sarcoidosis patients. These were the people who were shown to be at higher risk of developing COVID-19 if they have had sarcoidosis. A lot of factors were not associated with an increased risk of developing COVID infection in sarcoidosis patients. Age, sex, race, the presence of cardiac sarcoidosis, the presence of COPD, hypertension, diabetes, heart disease, or whether the diagnosis was less or more than 5 years of sarcoidosis, none of those had an impact on sarcoidosis patients developing COVID infection. There also was patients on immunosuppressive drugs for sarcoid other than rituximab, which I already said increase your risk of getting infection, but prednisone, and when we looked at getting 10 or less milligrams of prednisone, or Remicade or Humira, or Plaquenil, or methotrexate, or azathioprine, none of them were associated with an increased risk of contracting COVID infection. In terms of hospitalization, because I've been talking about the risk of getting infected with COVID, I haven't been talking about if you get infected, are you going to have a poor outcome? Well, from the survey, it looks like patients who were treated with any of these drugs, including rituximab in this case, if they got infected, did not have a worse outcome. They were not more likely to be in the ICU or be on a ventilator. Hospitalization was more common in sarcoidosis patients who had underlying heart disease. I think it's important to note that even though we had 5,200 patients, these sort of results are still questionable because we only had 114 people who were infected and only 19 were treated in the hospital. So we have a very small number of patients to make these conclusions on. But these are the results that we found. So to kind of summarize the data, this would be how I would interpret it. COVID infection may be slightly more common in sarcoidosis patients than the general population. We seem to find that result, but as I explained to you, that's a hard statistical analysis to be sure of. COVID infection was not more likely in sarcoidosis patients who were receiving any immunosuppressant agent except for rituximab. There were no race or sex differences in sarcoidosis patients acquiring COVID infection. COVID infection was more common in sarcoidosis patients with roommates infected with COVID and in healthcare workers, which makes common sense because, as I told you, the most important thing to prevent infection is this mask and social distancing. And when you're living with someone who's got COVID, or you're a healthcare worker who's treating patients with COVID, your risk of getting it are higher. COVID infection was more common COVID infection was not more common in sarcoidosis patients who had diabetes, hypertension, heart disease, or COPD, and no risk factors were associated for a poor outcome if you became infected with COVID, unless the sarcoidosis patient had heart disease. As I said, there are some limitations of this survey. The first thing is we can't guarantee that everyone who responded had sarcoidosis. They probably did, but we can't guarantee that. We cannot guarantee the accuracy of the responses via the medical record. The patients may say they had lung and eye sarcoid, but we don't have no medical documentation of this. And it's possible that the responders may have completed more than one survey. But I think many of these limitations are pretty minor. I think most of the patients did have sarcoidosis. I believe the responses were probably accurate. I don't think too many completed more than one survey. One problem is that we only had 114 incident cases. What that means is there were only 114 patients who had COVID. And that's a small number. So a lot of our data may be inaccurate because of that. This may be a bit too technical, but if you have a small group of patients, then if you try to predict what a value of the population is, it's a wide prediction. So you may not be able to tell differences between groups. When you get more patients, then you make the probability curves narrow and you can see real differences. So what I'm saying in a long-winded way is that because we only had 114 patients who had COVID infection, some of our conclusions may be more accurate if there's more data on a larger number of patients with COVID infection. We may not have as refined results as we'd like. My personal interpretation of this is that the risk of acquiring COVID-19 infection is probably increased very slightly in those on anti-sarcoidosis medications, except for rituximab, but social distancing is probably the most important thing in terms of avoiding COVID infection. And the usual risk factors for a poor outcome in COVID infection probably apply in sarcoidosis patients. We didn't see all of them, but I think it's because of that last fact I mentioned, because of the number of cases was small. So we didn't really see some risk factors show as significant in these patients. I think that this is interesting, but I think we need more data, and we're going to continue these surveys to try to clarify what we found so far. So with that, I'll stop, and I'll be happy to answer questions.
Hi, everybody. Hello, Dr. Judson. Thank you so much for joining us. Everybody just got through this awesome presentation, so I'm excited to head into the Q&A session. So you guys will have to just bear with us a little bit. We're going to try to do this as succinctly as possible. I'm going to be reading off the questions that Dr. Judson will then answer them. And the first question that we have on the panel is, did our survey include patients who passed away from COVID-19?
No, it didn't. And that's an important point, is that some of the patients may have died of COVID, and so obviously they couldn't complete the survey, and there was no way for that to be arranged. So again, given this number, there probably were very few deaths, but they were not accounted for.
Thank you. The next question we have is from Jen, and she says, based on my own experiences and those who are part of the sarcoidosis Facebook group, SARC patients seem to have isolated at a much higher volume than the average person. If we have isolated more than most, doesn't that also skew our understanding of how likely sarcoidosis patients are to contract COVID?
I think that would be true if we really know if sarcoidosis patients are isolating themselves more. I'm not sure how that would be difficult to prove. Certainly the patients that I see seem to be doing that, but I don't know if that's really the case, to be totally honest.
Thank you. Then our next question comes from Frank, and he is asking if we've been dealing with people who had COVID and if they're getting the long-term COVID side effects that are sort of exacerbating sarcoidosis after being cleared.
Again, one of the issues here with a lot of these questions is the easiest answer is I don't know, but all I can tell you is what I've seen in the patient in my sarcoidosis clinic. I have a large sarcoidosis clinic, and I am seeing the typical sort of sequela consequences of COVID. I'm seeing patients with prolonged fatigue. I'm seeing patients who have a rapid heart rate. That's a very common complaint, is they have a rapid heart rate and they do simple activities and their heart rate's going up much higher than it usually does, even to the point of causing shortness of breath. And I'm finding that typical to the general COVID population, these symptoms generally are self-limited and usually last on the order of 2 to 3 months. But again, I'm just talking to you as one doctor who sees a lot of sarcoidosis patients. There's no hard data on this.
Thank you. And then the next question we have is around PPE. And should patients or people with sarcoidosis wear face shields and goggles? Also, are N95 masks recommended over cloth surgical masks when out in the general population, especially for those with sarcoidosis?
Again, I hate to keep being like a broken record. I don't know if we know specifically for sarcoid, but I think the prudent response would be to respond in terms of what every person should do. And I think the sarcoidosis community would basically fit into what the general population should do. I think that eyewear is more protective. I think this is particularly important in closed environments, indoors, especially when ventilation is poor. So I would recommend that. Especially if you're in an environment that's closed, it's indoors with a significant number of people, I would probably recommend that. In terms of an N95 mask, this is an issue which is unresolved and is major. And if you've been reading the news the last week, it's still an argument in terms of the CDC recommendations and the WHO recommendations. It was in the New York Times a few days ago. It appears that COVID-19 can be transmitted by droplet, which means it's in kind of a moist particle or a small drop, but it also looks like it can be aerosolized. The difference is that when it's aerosolized, it can stay in a closed environment that's not adequately ventilated for hours. If that were the case, that would suggest that an N95, if you're indoors, might be the ultimate form of protection. The problem is that, honestly, pragmatically, we don't have enough N95s even in hospitals to supply the population. And number two, it's also not clear, even if a few COVID viral particles are suspended, how infectious is that really? We really don't know. And so this is an ongoing debate at the highest level in terms of what is sufficient. I would say that a cloth mask is better than nothing. A non-N95 surgical mask is probably better, and an N95 maybe even better, but we really are not sure how much of a difference that makes at this time. If I could, I don't know if it's, if we have enough time, I'd just like to could I just make a few points?
Yeah.
Because things are changing so rapidly. I don't know if people know, I gave that discussion of the survey about 2 weeks ago. Things are changing so rapidly that even the last 2 weeks, some things have changed from what I've said. And this is very typical of COVID. We're still in the very steep part of the learning curve. One of the things that we've learned is a paper was published in the rheumatology literature, very similar to ours. with rheumatology patients. And no, they don't have sarcoidosis, and it's true what they found in that paper may not directly be applicable to sarcoidosis, but a lot of those patients with rheumatologic diseases use the exact same medicines that we used in sarcoidosis. And so we should pay some attention to what's in that paper. Why that paper? That paper was a much bigger number of patients than we have. If you go back to our paper, we had 104 COVID-infected patients out of the 5,200 who took the survey. They had 600 patients who were infected with COVID. We, in our survey, only had 18 patients who were hospitalized, who had severe COVID. They had 277 that were hospitalized. So we have to at least pay attention. It may not directly relate to sarcoidosis. I think it does, but even if it doesn't, we have to pay attention to their data. What they found was they found that patients who were on 10 or more of prednisone, even though in our study we didn't find a difference, but we only had 18 patients hospitalized where they had 277, they found that patients on more than 10 milligrams of prednisone did worse. They were hospitalized more with COVID than those who were not on that dose. They found something also extremely interesting, a little weird, but interesting. They found that patients on TNF-alpha antagonists, like Remicade or Humira, if some of you listening are on those medicines, had a better outcome. They were less likely to be hospitalized. Now, what does this mean? I'll tell you how I interpret this. What we found with COVID is that when you get infected with COVID, the first problem you have has to do with the virus, the COVID virus itself. It gets into lung tissue, it gets into your nose and blocks your sense of smell, and it starts attacking your own body tissues and causes harm. But then after a while, after about 5 to 7 or 8 days of infection, the immune system attacks and destroys the COVID virus in most cases. But the problem is often the immune system gets overstimulated. And so it's your own immune system in COVID-infected people that causes damage. So you could see that drugs that block your immunity might hurt you with COVID because you're more likely to get infected and you're more likely for that infection to kind of grow deeper into the body. But at some point, blocking your immune system would actually help you because after you fought off the virus, now your immune system is too stimulated. So this is why prednisone has been shown in people who go into the intensive care unit to actually save lives in COVID, where in this rheumatology study, giving people who were on steroids when they got infected did worse. So here's an example where timing makes a difference. A drug at an early phase in COVID infection may hurt you, but that same drug later in COVID infection may help you. So this, I think, is very interesting how so this makes sense that TNF-alpha drugs, even though they immunosuppress you and may cause you to get more COVID, in the end may actually help you with COVID. And this shows just how complicated teasing this out really is. So I'll stop there, but this is fascinating to me, and it's all come out in the 2 weeks since I gave that talk. And I'll be happy to keep answering questions.
Thank you. I think that's a great perspective. You actually answered a bunch of questions sort of in that, so that's good. Just so you guys know who are on the call, I'm going to go ahead and kind of try to group some of these questions together so we're not sort of asking a little more popcorn style. So we have quite a few questions around the survey and whether or not we will be releasing those results somewhere specifically. And additionally, the other sort of half to that question is, will we be reopening the survey for people to add new information, or will there be a second round of information results available later as well?
Yeah, well, the first thing is the survey is going to be published, and at this point it's aimed at being published in the International Sarcoidosis Journal, and obviously it has to be approved for publication, but there's a process going forward, and I think it has an extremely good chance of being published in the near future in that journal. I think for the reasons I already mentioned, we need to continue the survey. Even though 5,200 patients sounds like a lot, as I said, we only had 18 hospitalized and we only had 104 that are infected. We need a larger N a larger number of patients. We call that N in clinical research. We need a large number of patients to really make more definitive statements. So yes, we plan to continue these surveys.
Thank you. And I think we have some sort of one-off questions. One that's been mentioned a couple times is, do you recommend the flu shot for people with sarcoidosis, if you're willing to go on record on that one? And then sort of, how isolated should someone with sarcoidosis be in this space? Should they really be hunkering in at home? You know, I mean, I'm sure that's a hard question to ask.
Yeah, all right, well, I'll take the first question because that's easier. Get the flu shot. I would recommend getting the flu shot, although I'll make a comment, which is interesting, in that, you know, in the Southern Hemisphere, their flu season is different than our flu season. And guess what? In Australia, the rate of the flu is about 1% of what it normally is. And a lot of people think that because of the social distancing we're doing for COVID, that's really going to shut down flu. Now, I wouldn't assume that. I would get the flu shot. I would definitely not assume we're going to have a light flu season. But a lot of epidemiologists who study this feel there's a very good chance we'll have a very light flu season because of precautions against COVID. The second question you asked is incredibly difficult and really can't be answered other than to say the following. And I've kind of rehearsed this because I've had this question 100 times from sarcoid and non-sarcoid patients. How meticulous should I be in protecting myself from COVID? Well, certain people are at certain risk of COVID, but still the ultimate, it still boils down to how careful should I be? And really, it's a matter of personal judgment. It's a matter of how risk adverse you are. Me, I would never skydive. No way. But there are people who skydive. Why is that? Because they're not as risk averse as I am. They are willing to take the risk of skydiving, and I am just not. We all have a level of threshold of risk that we're willing to take. I go out and I go to the supermarket. I don't go as often as I used to. I try to stock up when I go there, but I go there. I'm taking a little risk in doing that. So it's really hard for me to answer that question. The more you isolate yourself, the more you follow the CDC recommendations, the safer you will be. Where you draw the line, because you have to live your life as a human being, where you draw the line, that's personally up to you.
Thank you. I think that's excellent advice. I think we have a couple other questions around whether or not there will be a COVID vaccine and if that might be live, because we have some folks who mentioned they shouldn't be getting live vaccines from their doctors have said that. So we actually had a couple questions almost phrased identically to that question.
Yeah, there are many vaccines that are in the process of being evaluated. They're undergoing study. A few of those vaccines are live. They're not COVID vaccines, but there's another virus vector that's kind of taking the genetic material of the COVID or the antigenic material into the patient. Most of them are not live vaccines. So we'll just have to probably see how this plays out. My guess is that we will have multiple choices of vaccines, and several of them will not be live and will be suitable for people who have contraindications to taking live vaccines.
Thank you. And kind of along those lines, so we definitely have a couple questions from folks around Plaquenil and whether or not, if they're not on it, they should get on it to prevent COVID.
Plaquenil has been studied, and the studies, like all COVID studies, let's be honest about it, they're not rigorously designed studies. Why? Because a lot of these patients are very sick or dying, and they just want to, the doctors just want to give them medicines. But that's really not the ideal way to do a study. I can understand that. So the data is a little bit flawed, but most of the data we have does not show a benefit of hydroxychloroquine. I am not routinely giving hydroxychloroquine to patients with COVID, and the current recommendations have eliminated hydroxychloroquine as a routine therapy for COVID. It looks like from our data and that larger paper I mentioned in the rheumatology literature that hydroxychloroquine does not hurt people who get infected with COVID. So I think hydroxychloroquine at this point, our current knowledge is that it's neither a positive or negative. If you're on it, stay on it. But getting on it will not help protect you against COVID, of getting COVID or of having a milder case of COVID.
Great. And then we have a couple questions. I know that the holidays are coming up, so we have a few folks who are asking about whether or not it's safe to fly, particularly if you're on certain kinds of medication. Inflectra is mentioned, as is Axar and prednisone.
Okay, well, this goes back to two things I mentioned before. One is risk aversion. Every time you go on the plane, you are taking some risk because you are in a closed environment with air that's not being ventilated real well, and you're at the whim of everyone else on the plane who may or may not want to wear a mask. And when they come around to give drinks or snacks, people have to take their mask off to eat and drink them. Now, do people fly? Yes. But again, this is the decision you have to make. You are exposing yourself to some risk on a plane. I personally am not flying now. And I would not fly unless there was a family emergency and I had to fly. That's my assessment of risk. But, you know, this is again, goes back to the same point. How much risk are you willing to take to see loved ones that you haven't seen in a while? Maybe you're willing to take the risk. It has to be a personal decision in the end. But there is some risk in being on a plane. There's just no doubt about it. Oh, and the other part about the drugs, I mentioned the drugs. Again, I'm going to rely, you know, what we do in medicine, especially in a situation like this, is we're learning on the fly. We've got slammed with this virus in the United States in February and March, and we're learning from this point. And we're just trying to navigate as best we can with limited data. With the limited data that I have, I would say Athgar gel and prednisone over 10 milligrams does pose, I'm relying on the rheumatology data, which is different than our data, remember, that we just presented, but the numbers are so much greater with the rheumatology data. I think it does pose some risk of having a worse outcome with COVID. In terms of Inflectra, that's really a TNF alpha. The data would suggest that actually, I wouldn't get on Inflectra for that reason, but the data seems to suggest those people do a little better who get COVID. So I would not be as concerned if I was on Inflectra as I would if I was on more than 10 of prednisone or on high dose Athgar gel. But again, this is a guess. This is a guess because we just don't know.
Right. And we appreciate it. Thank you so much. I think we have one other sort of quick question around drugs since we're on that topic, and that is if you're on multiple drugs, for instance, prednisone, Celezept, and Remicade, do being on multiple drugs have any kind of indicator for risk for COVID?
Good question. You would think common sense, the more drugs you're on, the more risk. However, most people are on those other non-steroid drugs, non-prednisone drugs, for the specific purpose of lowering the steroid dose. And I think if you, again, if someone looks at this 2 years from now, I may be embarrassed because I may say something which turns out not to be true. But on the data that we have right now, it seems that the methotrexate, azathioprine, mycophenolate, hydroxychloroquine probably have very little risk. Prednisone over 10 milligrams probably has a lot of risk. And I just told you, Humira, infliximab, Inflectra may even lower your risk. So the bottom line is any drug combination you can do to lower the prednisone probably is going to help you more than it hurts you. So if you're on 3 drugs, but the drugs are there to lower the prednisone dose, that might actually protect you from having a bad outcome with COVID.
Great, thank you. So we are getting down to the end of our time. We've got 10 more minutes before Dr. Judson needs to go, but I just want to reassure everybody that we are collecting all of the questions through the Q&A and that I will collate them and send them off to Dr. Judson for some answers, and we'll get those out to folks after the summit later, not probably this week, but probably next week if we can. So with that being said, we do have a question around antibody tests. And if you have been someone who maybe got sick in April, but you weren't able to get a test, does it make sense to get an antibody test? And then the other question that we have around antibody test is, should I make my friends and family get an antibody test so I know if they can be in my bubble?
Again, I'm extrapolating. We don't really know the answer. It looks like the antibodies are only present for a fairly short period of time, maybe months. Obviously, some people probably have it for many years, maybe some people less. Some people who clearly have COVID don't even mount an antibody response that we can detect real well. I don't think the antibody test is going to be that useful, especially on making decisions about whether someone can come in your bubble or not. The issue is that the antibodies are formed from certain white cells that make the antibody. And when that infection is clear, those white cells, they kind of take a break, they take a rest, but they're still there. And if you were to get infected again, they would quickly activate and probably raise the antibody level again. I'm just speculating, but this is what a lot of viruses do. The reason I make this point is that just when your antibody levels go down, it doesn't mean the person is not still protected. We don't know if they are. My guess is they are, but I may guess wrong. So the bottom line, as you can see, as I'm kind of rambling, is that we really don't know what to do with the antibody test. It shows that you were infected at one point. How much protection it provides you, whether you have an antibody or don't have an antibody, we don't really know. My guess is if you have antibodies, you have those white blood cells in your system, you could probably mount some response again, at least for a few years, and you're probably protected to some extent, even if the antibody level that's detected goes to zero.
Thank you. Yeah, it seems like there's just so many unknowns upon unknowns here, and it changes every week. So we definitely appreciate your work here. I have two final questions. So the first question is, again, this is around risk. So I can imagine we've got a lot of questions about risk, but one of the questions is really about, should you see like your ophthalmologist or dentist or dermatologist for more routine type exams right now, or should you try to maybe put those off a little bit until at some other point there's a vaccine or there's less cases in your area?
Yeah, again, that's a question of risk, but I think you can also be a little proactive here. A lot of these follow-up appointments are kind of nebulous in terms of when the follow-up is. I mean, we say a year. Does it really have to be a year? I would be proactive and ask the doctor. I would be proactive and talk to the nurse or the doctor and say, hey, I feel fine. I have no problems with my eyes. Do you think it's okay if I move my appointment out? And you'd be surprised. A lot of doctors will say, yeah, that's reasonable. So I would be proactive and see, certainly if the doctor's willing to put the appointment out, it would lower your risk to wait, and I think then it would be safe to do.
Thank you. And so this might be our final question here. Maybe I'll just squeeze in one more past this, but from someone with pulmonary sarcoidosis, does COVID-19 cause more scars in the lung tissue?
Yeah, another great question, which I have absolutely no idea of the answer. Again, if I took a guess, I would say probably not much more scar. The scarring from COVID seems to be self-limited and seems to usually resolve, with some exceptions. If you go to the ICU and get really sick, maybe not, but a routine COVID infection, you probably won't get much scar. And the scarring from sarcoid, we think is a special type of scarring. So this is just a wild guess. I don't know. I would think it's not going to really increase the scar from sarcoid.
Great. Oh, I think I can squeeze one more question in.
Sure. Yeah, absolutely.
So is there a high, or what is the sort of false negative result for COVID test? And I know this varies across the type of COVID test you got, but could you unpack that a little bit so people can better understand what kind of COVID test they might get and what the sort of false positive rate might be for that? I think there are just a few of them.
Okay, well, I'm not exactly sure. There's two types of tests. There's antibody tests. There's also just test do you have the virus. So in terms of test if you have the virus, that test has a ton of false negatives, probably 20-25%. It doesn't have many false positives, except, in other words, if you get tested and they say you have COVID, then the odds are overwhelming you have COVID, except for one thing. Even when you recover from COVID, that test can still be positive. In fact, it very often is. We actually did a study of this. And in people who are completely cured of infection, 14 to 27 days after infection, if you test them for COVID, they're going to be positive, 60%. So in terms of testing for COVID, there are a lot of false negatives where you actually have COVID, but you test negative, and there are very few false positives, but it stays positive even after you're cured of the infection.
Thank you. Okay, one last question, I promise.
Sure,
It's
that's
the
fine.
last
We'll
one.
take it. We'll take it.
And this, I'm just going to read it. And so it says, we know that AC levels seem to be involved in sarcoidosis. We know that it's ACE2 receptor and how COVID-19 virus gets into the body. Any ideas what's going on there?
Well, to make a long story short, those are not really related. It is the angiotensin converting enzyme, but in the interest of time, they seem like they should be very related, but they're really not.
Awesome. Okay, well, we know you do need to go because you're squeezing us in right here at a very tight bit of your schedule, and we really, really appreciate your time. And I will follow up with an email with any additional questions that didn't get answered. I think we got most of them. We're down to just a few, and some of those are repeating kinds. So thank you, Dr. Judson, very much.
My pleasure to do this, and I'd be happy to answer the other questions when you send them to me. Be happy to answer them. I hope everyone stays safe and stays well.
Wonderful. Thank you so much. Take care.
Okay. Bye.
Bye-bye.